I was the Chief Executive of the National Health Regulatory Authority in Egypt, in Bahrain, I'm sorry, and member of the Supreme Council of Health, that's the one making policies. Currently, also, I am Clinical Associate Professor at the Arabian Gulf University College of Medicine. I'm the Chief Executive of a private company. I'm the owner also of the company. We do consultation in health services. We do feasibility studies, but for major projects, not for small projects. We did a lot of studies and work for the government, particularly because we are the only ones who are specialized in mathematical modeling of prevalence of diseases. I think we need to see the major public health problems that countries in our region, and when we talk about our region, we talk about Asia, Middle East, North Africa. We're not going to talk about other countries, but we talk about our region. And we will find that the major public health problems are related to cardiovascular diseases, diabetes, oncology, cancer in general, trauma, gastroenterology, and genitourinary, and a group we call it miscellaneous. In any country, when you see the prevalence, morbidity, and mortality data, and you try to reach general understanding what are the major problems, you will not go outside that graph. You will find the cardiovascular constituting about 30%, maybe a little more, a little less, diabetes approximately 20%, and so on and so on. Now, what happened when COVID-19 hit the globe? Many countries made a lot of decisions. We are not at all discussing what countries did, because this is the privilege and the authority of each country. But what happened is this: closing down hospitals, keeping them only for COVID-19, stopping a lot of elective admissions, elective surgery, and this is the effect, the impact of COVID-19 on diseases. Severe impact on cardiovascular diseases, severe impact on diabetes, on oncology, and on chronic kidney diseases. Of course, minor impact on trauma. Why? Because a trauma, no matter what, you have to take care of it. But let us take diabetes, for example. You have a patient, early diabetic, and suddenly, for 1 year, he cannot have proper comprehensive care. And when you talk about comprehensive care, that means preventive, curative, rehabilitative. Suddenly, he can't go to a hospital. Suddenly, even, he can't go to a health center because of COVID-19. And with all due respect, when you tell me that we will examine you by video, it doesn't work. If a person is having minor changes in the retina, it's under the term of diabetic retinopathy, you don't discuss this by video. You have to examine the patient. But when you tell patients, don't come unless it is extreme emergency, you see what damage is happening or will appear within the coming 2 to 3 years. Those with early conditions will come to you late. In oncology, for example, early diagnosis will be delayed. Instead of seeing a case in stage 1, you may see the case in stage 3 or stage 4, where treatment is becoming only palliative. So the impact of COVID-19 on diseases is really severe, and it will appear in the coming 2 to 3 years in a form of serious non-communicable disease increase in the prevalence and in the severity. So that's, we have to be careful. COVID-19 is going to stay with us for a long time, and other diseases may come, but when other diseases arrive, we should take a lesson from what we did to our health services because of, I'm sorry to say, tunnel vision, looking only how to control COVID-19 and forgetting the bigger picture. The bigger picture is the other non-communicable diseases, the one that really hurt the community. And who are helped more? If you look at this one, you find in any country, this is the graph of the aging population. Because of development and improvement in health services, non-communicable diseases are on the rise, communicable diseases are on the decrease. So people becoming age rapidly and they live longer. You will find that within the coming 10 years, probably 10 to 15% of the population will be 60 plus. And if you continue for another 10 years, you may reach 20%. These are the vulnerable people for non-communicable diseases, and these are the ones who are hit hard by COVID-19. Stay at home, don't leave home, don't go anywhere. Okay, they are sick with non-communicable diseases, and unless they are monitored properly, cared for properly, and here again I have to use the word comprehensive care, not incidental care. If someone is hypertensive, just measure blood pressure, give him the medication, bye-bye, finish. What about the effect on the kidney, effect on the eye, effect here, there? We have to be careful when we deal with cases, comprehensive care. COVID-19 destroyed what we call it comprehensive care and converted health services into incidental care. Many may disagree with me, that's fine. Disagreement is important, but try that we at least consider that in the future we should look at the whole picture and not in one particular disease and let the others slip away from our hands. Now, the other part that I want to talk about is the management of health services in general. And this is interesting because based on long experience, I have been in the business of healthcare management over 45 years, and I have seen a lot. So let us see exactly what we have here. Someone comes and say, here is a building, I have the manpower, I have the money, this is a hospital. So a hospital equipped, doctors are there, nurses there, technicians there, auxiliary there, and the money is there. Will you consider this a proper facility? The answer is no, because you have to see how will you deal with the resources. So you need to have the proper process, direction, strategy, administration, policies, and procedures. So you have the resources and how to use the resources. This is not enough because you have to see the outcome of managing the resources in the sort of quality care, efficiency care, and safety to patients, visitors, and staff. We call this the static model. Why? Regrettably, you find this everywhere. You have the facility, you have the policy guidelines, you have the administration, you have everything, and you have the outcome, but you are not moving much to improve the outcome. So to make the static dynamic, here is what is required. You analyze the outcome. When you analyze the outcome, to improve the quality, to improve efficiency, to improve safety, how will you do that? Either you make changes in the resources or you make changes in the process. You change allocations of some resources to improve something or to decrease from others, change the policy guidelines in order to improve the efficiency. So this, we call this the dynamic system. But one question here. This is in isolation of the community. You have to see what are the demands and the needs of the community. Demands, that means immediate requirements. Needs, that means future requirements of healthcare. So we look into the next one here. Research and development unit must be there. So it will be the link between the community and what services you are providing. That will be the responsive dynamic system. You have the resources, you have the processes, you have the outcome, and you have the research and development unit, which, by the way, you don't need to have a full research unit like university research unit. No. You need just proper analysis of data that you have and match it with the national data so that you can see where you are and how can you improve your services to better serve the community. To make the whole system on a national base, you need to add a research on a national base. Sometimes they call it planning unit, but planning unit is, let's call it a vague term. Better to call it what it's supposed to be, health service research unit. What the unit will do, identify national demands and national needs, look at what you have, what you serve, and what services you are providing, and see what are the gaps between what the national services require and what is actually being offered. That gap should be distributed everywhere to investors, to current services, to tell them this is what we need so that you can close the gap of services. What will the National Center will do? It will analyze the national data, it will model the data, it will have the strategic outcomes, and from strategic outcomes, you see the gaps that need to be covered. These gaps will be the opportunities for investors. So when you have an investor in a health service, you tell him this is what is missing. So he will be on the right track, rather than building a facility and just compete with others and leaving the gaps increasing or widening. And this is what will happen if you here this is in most facilities. You have the two areas of missing or not communicating. The research and development within the facility and research and development in the country. Either they're not communicating or something is missing. The whole thing is missing. In this condition, you end up having this. Systems will stagnate. There will be dissociation between services provided and demands and needs of the community. Gaps in services demand start appearing and are very difficult to manage, because you see, if you don't anticipate the problem and try to work before it becomes a real problem, then you are reacting, and the reaction is always way below what is supposed to be if you compare it to proper planning. So you act rather than react. And of course, that will end up in deteriorating quality and increasing medical errors, and at the end, deteriorating efficiency.